video and mic turned off. Thank you so much for participating in the rehearsal.
Thank you, Sue.
Starting the live stream to YouTube right now, and then we're broadcasting. Thank you for joining this ISAKOS webinar today. This webinar is presented on behalf of the ISAKOS Knee Arthroplasty Committee. The title is How to Deal with Infection in Total Knee Arthroplasty, a case-based expert panel. We would like to take this opportunity to sincerely thank the chairs and organizers of this webinar, Dr. Sebastian Lustig of France and Dr. Miles Coolican of Australia. Reminder, if you have any questions for the presenters, please utilize the question and answer icon. Please use the chat icon for general comments only. With that, let's turn over the webinar to Dr. Lustig and Dr. Coolican.
Thank you, Mike, and good morning, good afternoon, and good evening to everyone around the world, and welcome to this ISAKOS webinar on infection in total knee replacement. I'm joined by my co-chair, Professor Sebastian Lustig from Lyon, France, and I'd like to introduce our distinguished panel, Dr. Dan Washer from Albuquerque, New Mexico, Dr. Sam Usedek from London, England, Professor Philip Nerey from Lyon, France, Dr. Nico Budhiparama from Indonesia, and we'll be joined later by Dr. Andrew Price from Oxford in the United Kingdom. And with that, Sebastian, I'll hand over to you for the introduction, and then looking forward to starting the cases. Thank you.
Thanks a lot, Mike. Michael, if you can share the screen so we can see the slides, please. Perfect. So when we're talking about infection, we're gonna discuss, it's gonna be case-based. So we're gonna discuss several topics about, diagnosis, about therapy. We know it's gonna be crucial to try to identify the organism, and that antibiotics alone will not heal the infection. So it's crucial to identify the risk factors. We're gonna discuss that and to differentiate two types of infection. So it's going to be very interesting to see how we distinguish, acute and chronic infection. Acute infection usually are described during the first 12 weeks after, surgery, and we're going to try to preserve the implants. And chronic infection is when it's more than 12 weeks with more than 3 weeks of symptoms, and we're going to have to remove the implants. And we're going to discuss, all these topics during the next 60 to 90 minutes with several cases we prepared for our distinguished faculty. And I will hand over now to Miles for the first case. Miles, it's to you.
Thank you, Sebastian. Our first case, and I want to make it clear to the audience that our panel have not seen these cases. They are getting them for the first time. So it's an honest answer to a case they've just received, and hopefully they'll be able to enlighten us. So our case number one is a 66-year-old male who suffers from diabetes and hypertension, so some comorbidities, BMI of 34 and HbA1c of 6.1. So his diabetic control is not terrible. He presents with an antalgic gait, a range of motion in both of his knees from 10 to 110 degrees with fixed varus deformities and medial tenderness. And so he's a patient that potentially has a risk of infection. And I'm going to start by asking a panelist, Sam Usedek. Sam, what do you do to prevent infection in a patient like this? And I don't just mean what you do in the operating room. What do you do preoperatively? What do you do with skin prep in the pre-admission area? Which antibiotics do you use? Do you change your draping? What do you use in your pulse lavage? Do you use betadine? How do you manage traffic in the operating room? All those questions, please, Sam. How do you prevent infection?
Good evening, Miles and Seb, and thanks for the question. It's a good case. There's a bunch of different factors that you've raised there. In the preoperative phase, then careful patient assessments required. I think you've touched on some of the risk factors. So diabetic control is important. HbA1c is a marker that we can look at to try and estimate what some risk of infection may be. The literature on that's not particularly good. A value of 7.5 perhaps might be a cutoff for some surgeons. You might go as high as 8.5 for others, but certainly a high value you'd look to try and improve control preoperatively. Other risk factors, well, smoking we haven't talked about. You didn't mention that in your questions, but certainly smoking is a risk factor. Whether that improves once you stop smoking or not is a different question. And literature again is moot on that. Hypertension, not necessarily a risk factor for infection, but something you might want to think about, particularly if we're talking about fairly prolonged surgery for this patient, if you're considering a simultaneous bilateral procedure, which you might be. Intraoperative, or as we go through into the operative phase, skin prep important. I usually use clippers in theatres to remove hair. I use a ChloraPrep solution, which contains alcohol as my skin prep. I give it time to dry so that it can work. The operative field is then isolated in a standard fashion with drapes. You mentioned, I think, whether to change draping or not, which I guess is a reference to whether this is a bilateral procedure or not. If I'm doing bilateral surgery, then I tend to not change the drapes, but I leave the other leg, the second leg, covered and cut a hole in the stockinette, and then reapply some ChloraPrep with another iodine impregnated steri drape before continuing. I also change all of the sets between one knee and the other, just to reduce the chance of infection as well, so we don't reuse instruments. Antibiotics, standardized prophylaxis for us is cefuroxime, 3 doses, 1.5, 30 minutes before induction, and continued with 2 doses post-operatively. If they're penicillin allergic and we've got a nervous anaesthetist, then we might move on to clindamycin, occasionally ticaplanin and gentamicin, depending on the patient's profile. Were there any other factors you wanted me to touch on?
Well, one of the factors that's sort of starting to become more common is the use of betadine to either soak the joint at the end of the procedure, or to add 30 mils of betadine or one of the povidone iodine solutions to your sluice for pulse lavage. Do you do that? And what do you think of the evidence for that?
I think the evidence is pretty weak on that, to be honest. I don't do it. And in our institution, we don't do it. I know there's some weak evidence that, but the trouble is you need such an overpowered series to try and show any difference with a measure like that, that it's very difficult to show an effect. And, when you come down to it, that's one of the problems that we're probably going to run into when we talk about infection across the board, that it's a relatively, thankfully, rare event. And therefore you need, hundreds of thousands of patients before you can show the effect of such a small intervention.
Sam, what about dressings and wound closure?
Wound closure, I've standardized to using skin clips, which I think are effective. We close in layers. There's again some very weak evidence that using a monofilament suture might reduce infection, but once again, those are small series we're talking about. Sutures impregnated with antibiotics are another option. Again, there's some very weak evidence that might help, but I don't think it's strong enough to base a change in practice on. The only other thing that you mentioned, sorry, that I forgot to talk about was reduced flow through theatres. And personally, I think that is really important. And we do lock the doors and we do stop non-essential staff from being in theatre, as much as to stop the disruption to airflow as to the potential contamination from people sneezing or touching things that they shouldn't.
Miles, we have a question from with the Q&A about pre-op antiseptic wash and shower for patients before they come to hospital. Is it standard for you, Sam?
No, don't do that either. Again, I'm aware of weak evidence supporting it, but it's not something that we do. I do pre-wash all of my patients in theatre, but I don't ask them to do it for me.
Just out of interest, Sam, with respect to locking the doors, I tried to do that in my hospital and the fireman stopped me because there's no egress. So it's not quite as simple as you might think. Well, look, that's comprehensive, Sam, and thanks very much. We'll move on a little bit with this patient. In January of this year, he had a press fit total knee, was given 2 grams of kefazolin IV and discharged at 24 hours. At 2 weeks post-op, he was progressing well. His wound healed, staples were removed. At 1 month, he had some wound dehiscence, and his general practitioner started him on some oral antibiotics with Keflex, and referred back to his orthopaedic surgeon, where a superficial wound infection was diagnosed. His inflammatory markers were quite satisfactory with a CRP of 0.8. A superficial wound debridement was performed, a vac was placed, and he grew Enterobacter. He was given oral Keflex and trimethoprim sulfur. And I'm having trouble, there we go. At 7 weeks post-op, he was feeling well. And then a little later, at 15 weeks post-op, a pimple appeared 2 days before, and there was increased pain, but he was afebrile. What will we do at this stage, and what additional information would you like? And I'm now going to hand that over to Philippe Naray. Where would you go from here, Philippe?
Nice. The patient, what does the patient complain at the 15 weeks exactly? He has some pain?
He has some pain, which is more than he had. His pain is worse, and he has a pimple that's appeared. And if I just go back, I think I can show you that pimple.
Yeah, okay. So I first, during the surgery, I wanted to add, I would use some antibiotics in the cement. And also I would use a special surgical dressing like the Convatec one after the surgery, in order to avoid to have too many dressing after the surgery. But at this stage, it's not an easy situation, because of course he had this wound dehiscence just after the surgery. Usually when I have some skin problem, I ask to the plastic surgeon to give me an opinion, because it's not always we can obtain a good healing of the skin, particularly in diabetes. So I think I would be a little bit more aggressive in terms of second opinion from a plastic surgeon at the beginning. And also sometimes when we need to put some antibiotics, and we have also some tests for some microorganism, I think it brings some blue. But at this stage, it's not easy to decide what to do with this pain. I will do probably some blood tests, even if they are not always positive. I think this is a good information. I would check if there is any effusion in the knee joint, in order to know if there is a possibility to aspirate the joint. And I would also ask the patient to record regularly the temperature if he has a lot of pain. And of course, it seems to be a severe pain, but we don't know if he has pain during the night, if he has some inflammatory pain, and what kind of medication is he taking, and if the medication controls the pain.
Well, thank you, Philippe. Mike, if I could get you to advance that slide, I'm having trouble advancing it. So he did have an aspiration of his knee, and he had some we might advance it one more if you don't mind. Thanks, Mike. He had his knee aspirated, and you can see what came out looking at the syringes. And there were 96,440 white cells in the aspirate, so it's highly inflammatory fluid, and 88% of them were polymorphs. His bloods show an ESR of 100 and a CRP of 66, and cultures are positive for the same organism, the Enterobacter, that he grew at the time of his wound infection early on. So and it just advanced again, thanks, Mike. Where do we go from here? And to that, I'm going to pick on you, Nico. If you don't mind unmuting your mic and telling us what you would do at this point in stage. And one of the questions that's come through is the issue of whether it's an acute or a chronic infection, and whether or not we should be considering it chronic and dealing with it in that manner. So Nico, your care, please. Nico, you're still muted.
Thank you, Miles. Can I look at 2 slides for this? It started on the 15 weeks, right? Can I have a look?
Correct.
Before this? Before? Yeah, it's 15 post-op. Okay. So by this, I personally, you know, okay, no, wait. One slide before. Yeah, if you look at here, I think number one is that you have to differentiate whether it is superficial wounds or deep infections. As you can see here, that the doctor start to do the bleed amount. And after that, if you look at the culture, it is an Enterobacter cloacae. It is not common in Asia. Maybe it's more in Europe. So, if I'm not mistaken, this kind of bugs, the cloacae, it is an resistance for a cephalosporin. I think, yes, cephalosporin generation 1. So, but it has been given. So that is my point, number 1 point. And can I go further?
Yes, and Mike can, I'm having trouble controlling the slides. Mike could go forward.
Can go further. All right. But then it developed the pimples. If the pimple ready, I think it is a pimple shows that is maybe that is already an PGI, a deep infections. So can I go further? No further?
No, yes.
Yeah, this is already aspirated and it shows that it is a PGI. So by this, I would like to do an two-stage revisions, Miles.
Okay, thank you, Nico. Would everyone else on the panel agree that this is a chronic infection and that it's a 2-stage reimplantation? I don't hear anything different. Can we just move forward there, Mike? Again, I'm still having trouble moving the slides. There we go. So the following day, he had removal of the implants and irrigation debridement with an articulating spacer, antibiotics, and a PICC line, and he had IV antibiotics. Now, Dan, I'm going to turn over to you at this stage. You did the 2-stage. Just take us through this patient and talk to us about when you choose to use a 2-stage and when you choose to use a 1-stage for infection, and when is a DARE appropriate?
Yeah, so in short, we use DARE with the very acute post-operative infections. Again, this patient was over 3 months out, and he was one of my partner's patients who had done the superficial debridement, and I think he was probably seated at that point, and he might have been salvageable with a DARE at the initial wound complication, but unfortunately that wasn't performed. When my partner was out of town when this guy came back, he was floridly infected. Again, it had been 15 weeks post-op, had symptoms for some time, and my decision was to get everything out of there and do a 2-stage revision. In America, there aren't a lot of people that do 1-stage revisions. Certainly the literature seems to say that the success rate is equal, but I think the people that are doing 1-stages are picking the easier ones or the better prognostic ones, which may skew the results a little bit. But in our hands, we almost always do 2-stage revisions with an articulating spacer. And as you can see on the x-rays on this patient, what we tend to do is use an old femoral component and then do an all polyethylene tibial component as our articulating spacer with a lot of cement in the antibiotics, and we do kind of a sloppy cement job so that when we come back for the 2nd stage, it's not too hard to remove it and don't have much bone loss.
And Dan, your opinion on the difference in the morbidity between 1- and 2-stage revisions and the cost?
Well, certainly the cost is higher with a 2-stage revision. There may be a little bit more morbidity. But again, we have a lot of patients, and this is one of them, who come from very remote areas where it's very difficult to get good antibiotic management. And we just feel much more comfortable doing two-stage revisions pretty much routinely in our practice.
Okay. Well, I think I'll hand over now to you. I can see Nico is a question there. Nico?
Yeah, Miles. Dan, since 2019, United States, now it's becoming more popular to have this functional articular spacing with all poly. So that was my question now. In Europe, we do one-stage revisions. So what do you think of this? Why do you put an all poly instead of just like in Europe, we do one-stage revisions? Because most of the patients, if you look at the latest publications, that the patient, they should then come back for the reimplantations.
Yeah, again, in our hands, we've had better success with the two-stage revision. It's kind of what we've done. We're certainly paying attention to the European experience with the one-stage revisions. And there may come a time where in selected patients, we do one-stage revisions. As you mentioned before, Enterobacter is a bad bug. And I'm not sure most people would do one-stage revisions with an Enterobacter infection like this. I don't know, would anybody do one-stage revision in this case?
Well, I would certainly do a two-stage revision in this case, Dan, without much doubt. It's been present for 15 weeks. But we are going to go through in the next couple of cases the issue of DARE versus one-stage versus two-stage. So let me turn it over now to you, Sebastian, for case number 2.
Yeah, thanks, Miles. So, yep, that's it. So that case number 2 is about a gentleman, 71-year-old, active guy, walking, gardening. He's got HTO on the left knee in 2003, then a total knee in 2015. That's for the left knee. He had also a right total knee in 2016. So he has 2 total knees. But this gentleman has a very severe medical condition. He's got cardiac issues, pacemaker, anticoagulation drug, diabetes, and he had some ischemic cerebrovascular accident. Let's talk about the left knee. It's been okay for 3 years, but then it's been really painful for the last 3 months. No history of trauma or injection. Now he has pain day and night, exacerbated with white bearing. He's limping, falls down, and you really cannot stay in that situation. You can see the X-ray here. So his BMI is okay. Remember, he has a history of HTO, so he has 2 scars, one anterior, one lateral. The skin here is very fragile and thin. He's got swelling. The knee is warm and hyperalgesic. Range of motion is not too bad, 105 degrees of flexion. It's got no laxity, and the extensor mechanism is okay. So the first question is for Sam. Sam, you have the history of this gentleman, with his left knee, he also has a total knee on the right knee, but with no symptoms. And the question is, do you need additional examination? You have several options here. Lab tests, joint aspiration of the left knee, joint aspiration of both knees, or would you do an arthroscopy to get some samples and biopsies or other IDs?
Thanks, Seb. So interesting case and poor chap. So definitely some further examinations are required. So physical examination, he's got an effusion in the left knee, but the right knee is dry. The right knee is asymptomatic with a full range of motion. The left knee is painful and is stiff, from what I gather. So I would certainly do blood tests, an ESR and a CRP. I would schedule him for a joint aspiration, which I tend to do in the operating theatre on my next list, rather than doing it in the clinic. And we would get a white count on that fluid, as well as microscopy and culture. and I would be guided by that. But look, this to me looks and smells like an infection, so I'm going to want to be relatively aggressive in my treatment of it. And even if the aspiration comes back as negative, I'd probably get further biopsies in order to confirm a bug before proceeding with a procedure. And the whole time, of course, you need to just have at the back of your mind that this is a frail chap. You don't want to leave the bugs in his knee for too long, and you certainly want to be careful that he doesn't develop sepsis as a result of this probable prosthetic joint infection.
Afraid only the left knee, not the right one?
If the right knee doesn't have an effusion, I wouldn't go aspirating it, is the truth of it. I don't know if others would, but I wouldn't.
Other exam from the faculty?
Yes, Sebastian.
Philippe, yeah, Philippe.
Yes, I would try to check if there is a reason for general infection too, because this patient was doing very well for 3 years, if I understood correctly, and now suddenly he developed some pain on the left knee, and perhaps there is a reason, some door where the microorganism can come from. For example, the teeth or the colic problem or renal problem. So I would also try to have a more global approach to try to understand why we get infected, or probably infected.
Okay, Nico?
Yeah, I think in bilateral knee that you might need to do a blood culture as well. If sometimes it can be bacteremia, is what Philip already mentioned. So that is a good point that we have to do. And then the question now is, when do you aspirate also the other knee, the right knee? It's based on what Sam said. It's usually based on the physical examinations. If there's suspicion, then you do it and aspirations, right?
Okay.
I think that if the patient has hip replacement, we will not do an aspiration of the hip replacement if there is no symptom. So it's an interesting question, but I agree with Sam. If there is no symptom, there is no reason to aspirate.
Yep.
Okay, so we all agree that we need lab tests, aspiration, for sure the left knee, and that at that stage, if we get information from the aspiration, we don't need to go for a scope unless we don't have the answer. So these are you can see the numbers. ESR is 35, CRP 48. Joint aspiration, torpid color, leukocytes 3,500 with not more than 90% of polynuclear neutrophil. And after 3 days, you get staph epi resistant to methicillin and sensitive to rifampin. Regarding the synchronous potential, in infection, just to mention this paper, very large, data, 644 patients with an infection of one joint, and an arthroplasty is in at least one other joint. And what they found, and it was quite interesting, in that the incidence of synchronous bone, prosthetic joint infection was 4%, but then in 50% of them, it was asymptomatic. So which means that even if the other knee is asymptomatic, could be infected. And they managed to find some risk factors. And as you mentioned, Nico and Philippe and Sam, also clinical suspicion is the main factor. But also if you get patient with immune therapy or neoplasia or which are fragile, it might be relevant to aspirate the other knee, but the main criteria is the clinical suspicion. So that's completely correct. Then we mentioned, aspiration, blood culture, but regarding imaging, which kind of other imaging would you usually use for this specific case? And I will ask this question to Philippe.
I will ask for a complete radiological checkup, but I'm not so sure the long leg films are really interesting at this stage. We will focus mainly on the knee. Of course, we can need a long leg films if we consider to reoperate the patient and to remove the implant. So this is different. But in terms of diagnosis, I don't need that. If I want to change the prosthesis also, it could be interesting to have a CT scan in order to check the rotation. But if there is no clinical problem and so on, probably it's not absolutely necessary to have a CT scan. the bone scan is something we use frequently in France and in Europe, and the specialists of the infection like it, but I'm not so sure, and probably Dan can confirm that this is so popular in the US. And I am not certain there is a need also for any MRI with a special special software in this situation. So I think that there is probably a simple X-ray and a bone scan. I would obtain the image I need.
Other option from the faculty?
Yeah. Sap.
Nico, then Dan. Yep.
I think a CT scan might be helpful to assess the bone loss and whether it's the implant positioning. And I would like also to do some stress X-ray to look at to assess the laxity.
Good point. Dan?
Yeah, for me, when you draw pure pus out of the knee joint, I'm not sure additional imaging is that helpful for me, particularly when I'm planning a 2-stage in somebody with a chronic infection. You know, we'll deal with the bone loss and the ligament problems down the road when we do the 2nd stage.
That's because you go for 2-stage. So let's keep going. You know, so these are the different options. We discussed that regarding the X-rays, stress X-rays for the laxity, the bone scan, and as Philippe said, it's definitely not standard in most part of the world. And the CT scan could be interesting for a bone loss assessment. So now you have the full picture. And then what do you do with this patient? You know, how would you consider this case? Is very fragile, you know, medical history, is a high risk patient. He's definitely got, you know, a chronic, you know, at least seems to be like a chronic infection of his left knee. And these are the options that I would like you to consider. And I will ask to Dan, what would be your option, even if you already answered a little bit to that question?
Yeah, again, we tend to be very set on 2-stage revisions in our institution. He's loose, he's, you know, chronically infected. I think for sure, one's always a good option, but since we're the referral center, they tend to get sent to us rather than the other way around. 2, 3, and 4, I don't think are appropriate here. Again, I think 1-stage revision is certainly a viable option here. Depending on the organism you culture out. But again, you really need to have an identified organism if you're going to do a 1-stage exchange, I think.
Yeah, we all agree that there is not indicated here. Yeah, Mike?
Sebastian, can I just cut in for a sec? Because there's quite a few questions coming through on the Q&A with respect to mobile spaces. And one of the questions is whether or not the mobile spacer can be used as a definitive treatment of this. In other words, to take the implant out and put in a mobile spacer that would hopefully do the job for the patient forever, particularly in a patient like this. So perhaps Dan, because you're a 2-stager, maybe you could answer that question for.
Yeah. So what I will say is that when we do the mobile spacer and the infection is cleared, sometimes it's a long discussion to convince the patient to come back to have the revision put back in. And again, to me, if this is a less healthy patient, it's not unreasonable, again, to try to decrease morbidity and do a 1-stage in this patient.
Sam?
So I'm just going to play devil's advocate a little bit, if I may. You said straight off the bat that this isn't suitable for a DARE. Now, this is a frail gentleman. The history of infection is actually quite short, isn't it? I thought from the history.
Yeah, I mean, he's got pain for 3 months.
He's got pain for 3 months. I'm not sure that his implants are necessarily loose, and you can judge that clinically when you actually open the knee up. He's got a lot of pus in there. He's got a poor cardiac function, and actually perhaps doing a very small procedure with a staph epi that's known to have around a 50% clearance rate from a DARE, with using an antibiotic that might penetrate a biofilm, might actually be what this chap needs to get him better and not expose him to the extra risks of certainly having staged surgery, 2 big operations. So I don't know, just a thought.
No, it makes sense. We have to consider the medical condition as a key factor. Nico.
Yeah, I have another thought, Sam. If you look at the bugs, can you go back to the slide?
Sure.
This is a methicillin resistance, which is for the DARE. It's a poor outcome. Can you? Yeah. Resistant methicillin. So I think by this, I'm not agree with the DARE because the outcome is not that good because it's a resistant methicillin, one of the bugs.
So that's true for a Staph aureus. I don't know that it's necessarily true for a Staph epi. We'd have to have a discussion with a microbiologist about that, I think.
And so what about the one stage in that case? Because you don't want to consider 2 surgeries, and we know that the bugs is not so easy to treat. Some thoughts? Or you hate it? You hate the idea?
No. I think this is interesting to discuss this because, of course, we can be seduced by the fact to do only one stage. But if the one stage failed, it will be a disaster, you understand? So there is pro and cons. And I would say probably I would be more conservative like Dan Washer because I would be afraid to fail because for sure, if we fail with the one stage, it will lead to big general complications.
Good point.
Sebastian, there are just a few more Q&As coming in, and I'm having I'm having trouble keeping up with them. Several of them are on DARE and questions about what is the likelihood of a 2-stage being successful if a DARE fails. The second question is when should you DARE and when should you go ahead and remove the implants either with a 1 or a 2 stage? So perhaps we could put that to the panel. Sam, you were a DARE man. What do you know about the chance of DARE's failure then resulting in success or otherwise of a 2 or 1 stage?
Yeah, that's a really good point, and it's actually probably the major downside of a DARE when it fails. Having said that, you've probably selected out the infections that are easier to treat by that stage. So it's the more difficult to treat infections that may then go on to get treated by a 2 stage, and therefore the failure rate may be greater. So there may be a numbers game there that we're not quite grasping. So I don't think that the association is necessarily true about failed DARE and causing the worse outcome from 2 stage. Look, typically we're talking about acute infections with easy to treat bugs with well-fixed implants. And if we know that if we catch those infections early, then we can preserve the implants that are well fixed. And that has a reasonably good chance of success with the lowest morbidity to the patient. And so that's the attractiveness. That's not, now we're talking about a DARE, we're not talking about, washing the knee out, we're not talking about arthroscopic surgery, we're talking about a proper debridement of the knee and all the surrounding tissues and an exchange of the mobile parts, changeable parts of the joint replacement. So it is an extensive procedure. It does need long-term antibiotics. We usually combine it with, as I said, an antibiotic that's going to penetrate biofilm. And so it does have a reasonable success rate.
Yeah, Simon Young did look at this on the New Zealand registry, trying to work out whether or not DARE was associated with a greater failure rate. And I think in the New Zealand registry, their data was that it wasn't associated with a greater failure rate if you then failed a DARE and then went on to a 1 or a 2 stage revision series. Sebastian, back to you.
Yeah, that was great discussion, by the way. And just to summarize what we said, regarding the different options, we said that there, if the TBI is loose and it's a chronic infection, even if the guy is at risk, probably not, a high successful rate. And then we have to discuss 1 stage versus 2 stage regarding different factors we mentioned. So the international, consensus meeting recently tried to, document the advantages of 1 stage. We discussed that, decrease the surgical morbidity, earlier functional return for sure. And, the potential indication, so if you have a non-immunocompromised host, no systemic sepsis, minimal bone loss, soft tissue defects, the microbiology is in favor, so it's not a high resistant organism. you manage to isolate the pathogenic organism preoperatively, and you know the sensitivity of the bactericidal treatment. And there was a high consensus that in this case, one stage could be, a good option. And on the other hand, the contraindication are, of course, if you have severe damage of soft tissues, if you don't know the bugs, if you have no proper bone stock, or if you have a complex, sinus tract, all these are potential contraindications. But then the question is, how do you manage antibiotic therapy? You go for, one stage or two stage, but how do you do with the antibiotics? Pre-op, do you use effective antibiotic pre-op? Do you do just standard prophylaxis? Or do you do nothing until the samples are collected? And also post-op, do you do 6 weeks? Do you do 12 weeks? Then oral, or do you do lifelong oral suppression? And I would hand over to Nico for this one.
Thank you. Thank you, Zach.
Let's say we go for one stage, so it's clear enough.
Pre-op usually give a prophylactic antibiotic, that is to avoid super infections. And after that, post-op, it has to be multidisciplinary decision. Usually, I took 2 weeks for IV, and then total oral for about another 10 weeks. So totally it's about 12 weeks.
So that's exactly what the recommendation. So I think we agree on that we should avoid super infections, so standard prophylactic, and then the multidisciplinary decision will make the decision on the antibiotics. But usually it's a 12 weeks total, starting IV and then oral. And suppressive antibiotics, that in very specific case, like Sam just mentioned, and only if you have active, antibiotics on biofilm, of course.
I have a question for you, Sebastian.
Sure.
You say this is a Metier microorganism. Does it change anything in the management, the fact that this microorganism is resistant to the methicillin? And would you?
No, you're right. Yeah, definitely. It's in favor of two stage. It's in favor of two stage if we rely on the criteria. But that's a balance between, the risk of the patient, especially the skin. Will he be able to handle 2 surgeries or not? And then the bugs and the potential failure of one stage. You're exactly right. That's where the discussion and where the decision is not easy, and where multidisciplinary discussion and decision is crucial. So not telling this is right or wrong the decision we took, but we went for one stage. The reason were comorbidities and the fact that we know the organism. We went for the antibiotic therapy discussed with the ID specialist, and eventually it's been successful for 3 years now. So we've been maybe lucky, but that discussion between one stage and two stage was really meaningful on this gentleman with all these medical condition. I think that's important to have the whole picture when we make the decision, and not only to consider the knee, and as we've been discussing on this case. And then we just a couple of reference. One excellent from Sam, published in the BGG about the potential outcome of one stage. And what is very important is to select the right patient, and I'm sure Sam will agree on that. And that common sense is, as always in surgery, crucial when we make the decision. And I will hand over to Mike for the next case.
Thank you, Sebastian. Look, just before I go on to that, I'm really struggling to keep up with the Q&As, but there's several questions about spacers and whether it's sensible to leave a spacer in forever. There's I suspect, as you say, Sebastian, try and convince a happy patient that you want to take that spacer out and put another one in. Look, there's another question about what you do with the patella in the situation of a revision, and often it's the one with the poorest quality bone stock. So in a setting where you're going to do a two-stage, do you always remove the patella component, or do you sometimes leave it in a two-stage? And perhaps I'll ask your opinion and maybe the panel before we get on to this third case.
I would not consider letting the patella in. I would remove it for two-stage and then see how I can deal with the bone stock. I would not let the implant in.
And the panel, everyone agrees with that?
I agree with that, because you cannot leave all the poly inside there. So I agree with that. You have to remove everything.
Anyone
Yeah,
leave the patella in?
Well, Miles, I want to say we remove everything, and then if the patella is too thin when you come back, you can do a gull wing or just leave it unresurfaced, and it generally does pretty well.
Okay. Sam?
I don't necessarily take the patella out. The fear of getting shouted down. I'm very sorry about that. But it particularly if it's well fixed and there's not much bone stock left on the patella, I tend to leave it alone. I've never seen that come back and get me, but you know, I'm ready to be educated if someone's got evidence to the contrary.
Well, I'm in the same camp as you, Sam. And I mean, the other interesting thing about the patella is that if you've got a particular brand of implant in and you decide to use a different one for the revision, do you need to change over the patella to a different, to the brand of implant that you're putting in? And I think the answer to that's possibly it doesn't make that much difference. But we're getting off track and I've got to move on to case 3. This is a 72-year-old female who'd had a total knee 12 months ago, and the knee was always painful with a poor range of motion, restricted walking, and she had a wound discharge. And her surgeon referred her to a dermatologist to look at this skin lesion. And I don't know a lot about dermatology, but I think I could make a diagnosis of that skin lesion. So I think if I've got it right, it might be, Sam, your turn to comment on this patient. What's the diagnosis and what are the options? It's a total knee with a sinus.
Okay, so you know, she's got a diagnostic criterion of an infection, which is a draining sinus over the replaced joint. So the diagnosis is of a prosthetic joint infection. We're still going to run through all the same things we would normally. So we'd get blood tests, we'd get samples. So a swab of the sinus fluid is not particularly useful in showing us what the organism is. You'll often get microbial answers from that, but an aspirate of the joint, assuming some of the fluid isn't draining out, would again be useful. We get our samples done, we assess the patient, we assess the joint, we assess the bone, and we make a plan.
I'm glad you raised the question about aspirate, because 2 of the Q&As are, where do you do the aspirate? Do you always take the patient to the operating room to do the aspirate? And do you make a little incision to do the aspirate, or do you just put a needle into the joint? They're Q&A questions. Sam, I'll give those to you as well.
Yeah, so I tend to always do it in the operating theatre. I don't trust my clinic room to be clean or sterile enough to violate a prosthetic joint. So as I said previously, we tend to do it first on an operating list, and that might raise some eyebrows, and then we go and do some more operations afterwards. But you know, everything's cleaned very nicely before the first patient comes in. We tend to aspirate. If it's a dry aspirate, then under local anaesthetic in theatre, I might make a little incision over the suprapatellar pouch and take a synovial sample. But that's about the only time I'll do that. Otherwise, usually you can get some fluid out via a supralateral approach.
Okie doke, thank you. So we took it to the operating theatre. Now, this was in about the year 2003, and that's what she had done. This is my patient. She was referred to me for a second opinion. We involved plastic surgery, and that's what they did. Dan, can I ask you what you would do in the setting of that skin lesion with a little ulcer like that, which my plastic surgeon put a skin graft on?
Yeah, so I think, first of all, you get plastic surgery involved, but you need to have a plastic surgeon that's used to dealing with some of these difficult issues. Certainly, you have to, I think, be prepared to swing some sort of muscle flap, like a gastroc flap, in order to get good coverage there once you do your definitive procedure. And I think, you know, it'd be reasonable to use the wound vac and kind of treat it, you know, partially treat it. But when you come back to do your revision surgery and put your final implants in, I think you need to be prepared to swing some sort of muscle flap to cover that area, because otherwise I think the risk of wound breakdown is pretty high.
And Nico, can I ask, there are, again, lots of questions coming through about antibiotic holidays and how long this patient should stay on antibiotics. What do you do, Nico? And what makes you decide that it's time now to do the second stage?
Yeah, it is a very good question, Miles, because nowadays, if you look at the latest, the consensus 2018, that says that there is, you know, when you talk about the drug holidays, how long and how can, and who decide that the cutoff is 2 weeks? You understand? So don't, nowadays, people is not doing that anymore. But I have a question to Dan, actually. Um, um, if you look at the flap reconstruction, my question is the most important thing is the timing. When do you have to do it? During the explantations, or you wait until the after the infection is come down?
Yeah, I think that depends on how big the skin and soft tissue defect is. Certainly, if it's really bad with the infection, then you might need to swing your flap early and then have your plastic surgeon assist you on the exposure so you don't devascularize your flap when you go back in to put in your final components. But sometimes, again, you can treat it with just local wound care and then do your flap when you do your final revision.
But Dan, do you consider the flap is part of the treatment of the infection because it brings some blood and some antibiotics to the wound, and it allows the antibiotics to reach this zone?
I think there's some benefit of that, but I think the major thing the flap does is prevent recurrence from subsequent wound breakdown.
Philippe, can I ask you your regime for antibiotics and the decision that the patient's now ready for that second stage? Do you involve ID, infectious diseases, and do you offer the patient, or do you give the patients an antibiotic holiday?
No, it's it really depends the place where you are. The problem is in some place there is no very good specialist for infection, and we are not all prepared to play with the antibiotics. But the idea is to have a specialist of infection or to ask them their opinion, and I would for sure consider what they recommend in terms of antibiotics, and I would not be afraid to give them for too long time, and particularly in this situation. So what I would do is I would ask them to adapt the antibiotics. I will control the different blood tests before to reoperate the patient and to continue.
Thank you.
Miles, we have a specific question of in case of sinus tract, like in your case, do the panel, do the faculty think it's mandatory to aspirate the joint before going in surgery in this case?
Well, I'm happy to answer that. I think it's just so much easier if you know the organism. So in other words, aspirate the knee, and as Sam correctly says, you will not get the organism from the swab. You'll get polymicrobial answer there. So I think aspiration beforehand is appropriate. Just back to the issue of spaces, because there's been so many questions. This was a 2003 operation where you can see that's what we sort of colloquially call a hamburger patty. I would not use that now. This is a very old case. I would now use articulating spaces. And our patient, if I can just move forward, had a revision and is now happy. So we're running out of time, Sebastian, but over to you to case 4.
Yeah, perfect. This case actually is very, very interesting one. You will see we're gonna discuss a lot of questions. That's a tricky one. This is a female patient, 54-year-old. She's got pain in the right knee, and she had a total knee replacement. The history is total knee replacement done in, let's say, in another country. And she was okay for a couple of weeks. And then you can see the pre-op X-rays. And then that's the right knee. And you can see the post-op X-ray. We're not going to comment on this one, but you can see that after 2 months, she started to feel pain on the right knee. When she was white bearing, she had no swelling, and she was treated by her doctor with anti-inflammatory drugs, no improvement, and she went back to the hospital when she was been operated on in 3 months before. And you can see the X-ray here. So the first question is, again, how do you investigate in this case? And I would ask the question to Philippe.
Yes, I would do exactly the same than we said before. And there is a loosening of the femoral component. The X-ray are very small. I cannot see exactly what about the tibial component, but there is obviously a loosening on the femur and some migration of the implant. And so I would suspect and try to detect an infection with the aspiration, the blood test, and so on. And I will ask also for a CT scan, in order to check the bone loss and if there is some osteolysis somewhere. So I would do so, and also it will be helpful to control the rotation when we will revise the patient form.
Okay, good. So and this is what has been performed, the blood test, but you can see no ESR, no CRP. So that's the problem, in the initial management of this case, is there's been no aspiration. The surgeon did the diagnosis of aseptic revision, and we didn't get any information from the previous surgery. And so what has been...
Sebastian,
oh, yeah.
I would say that if you've got a loose implant, a cemented implant that's loose within a few years of surgery, it's infection until proven otherwise.
And it's not in several years. You see, it's in few months, so that's even worse.
Agreed.
So I agree, but the surgeon made the different decision, So he was like, oh, this looks aseptic to me, okay, and he did what might sound, I hope, crazy to everyone. He did a re-cementing. He get no samples, and you can see the post-op X-ray. So again, it's a re-cementation of the femur. I'm not sure about the tibia, and you can see that was in January, and you can see in March, how now is this ladies. And now in May, you can see it's getting even worse. So you can see the situation, you can see the scar. We have a video here. You can see I don't know if the video is running. You can see the laxity. She's got some slight, swelling. The scar is okay. She is no erythema, no sinus, no joint effusion, slightly warm. She's got some pain. Range of motion very limited, 45 degree, and you can see the valgus stress. You know the situation, and I would hand over to Sam. How do you manage this crazy situation now?
So I think this illustrates that complications such as sepsis provoke a grief response in surgeons, and the surgeon in this case never got past denial, unfortunately, and so we're left to pick up the pieces, it looks like. So you've got lots of lucency around it. You've got collapse of the femur, you've got bone loss, lateral femoral condyles collapsed, the components eroded into the medial condyle as well. I've never heard of re-cementation as a procedure, so that's a new one for me. So thank you. The tibia is tilted into varus collapse. There's an effective increase in joint space, which has led to that ligamentous laxity. Whether that's truly a ligamentous problem or whether it's just that the bone or the implants have collapsed into the bone and therefore increased the space available for movement, I don't know. But you have to go into this, I guess, with your eyes open and ready to deal with whatever you find. So the diagnosis is infection. I don't know if we've got any microbiological data back yet.
Not at that stage.
Okay. So look, you need to get your blood test done, your inflammatory markers, aspirate it, find the bug. And then this is a chronic infection with bone loss. For me, that's an indication for two-stage revision. I can't see a different way of dealing with it. I suppose the question would be perhaps what your spacer looks like in that situation with extensive bone loss, and whether you can get an adequately stable joint with an articulating spacer, or whether this is one of those rare occasions where you have to put something horrible like a static spacer in before you come back for your second stage.
Regarding the faculty, when do you guys could make the decision of using a static spacer? Miles mentioned it briefly, but what are your indications for a static spacer? Maybe Dan and then Philippe?
Yeah, so I tend to use static spacers when there's poor soft tissues. So maybe in Miles's case where he had that big sinus tract that was ellipsed out, I might use a static spacer in that case. The other cases in ones that have had multiple revisions previously and you don't have a lot of bone stock to work with, then we tend to use just a big IM nail up the femur and tibia, and then a block of cement in between. But that really lets the soft tissues rest if the soft tissues are somewhat compromised.
Philippe?
Considering the spacer, we can use a mobile spacer mainly when there is some condyle or still some epiphysis. If there is nothing, it's difficult to place a spacer that the shape of a femoral condyle. And also when I use a static spacer, I like also to fill the suprapatellar pouch or the place between the patellofemoral joint. And I saw that in a previous slide, Miles, you didn't do it. So I would do like this. But the question also for me is if the femur is particularly infected and probably also the tibia and the other bone, the idea is how does this infection extend to the femur? Because in some country like in Germany, they would be very aggressive with this type of infection with a very large resection and so on. So this is just my question. How do we evaluate the extension of the infection into the bone?
Okay, so now you have some information regarding blood tests. You can see the ESR and the CRP. And does it change something? Maybe Nico, you know this case very, very well. So how do you, this is, you have, it's not so high. CRP is not so high, but the femur is very loose. And so does it change something?
Yeah, indeed. That the CRP, if you look at the CRP, it's in borderline. But I forgot to say to you that this D dimer is about 3,400. And by this, I would like to do aspirations. So then usually, because if you can see, can you go back 2 slides before this and
sure,
show the clinical sign that, yeah, because you see that the joint effusion is none there. So I'm going to ask for the ultrasound. Can you go further?
Sure.
Yeah, go for it. Yeah, but the ultrasound shows only that some inflammation signs and inflammation of the synovial hypertrophy. Problem is that when we aspirate it, it is a dry tap. So maybe it is just to ask for the panelists, if the dry tap in this case, some suggestion they put in some saline on it. Do you suggest it or not? Or what Sam said just now, we got percutaneous, open it and do a biopsy.
That's the two options. Yeah, Dan, Sam, where would you go? You have a dry knee. Would you use some saline, irrigation, or would you open it a little bit to get some synovial samples?
So if I have
sorry, Dan, as I previously declared, I do synovial samples, so I'll pass over to Dan.
Yeah, so again, if I get a dry tap and I'm very concerned with elevated ESR and CRP, then I'll take it to the OR and do intraoperative frozen sections to make a determination that way.
And then that's just and again, I thank Nico for putting this case together, because that was very appropriate, that because that's something we have the experience in our all of us, that the day before the surgery, suddenly the patient has some fever, and we are in this COVID, environment. So you don't know if it's due to the infection or if it's due to something different. So of course it does compromise everything you've planned. And then another, blood, samples, and it's very surprisingly, luckily the COVID rapid test was negative, but also the PCR gets, suddenly lower. So that the question is, does it change something in the way you would consider the case? Maybe Nico, you can comment on that, because that's a very special case.
Yeah, this is very, very special. But I mean, nowadays, this is a good message to everybody in the world, because it's becoming now, the gate is open. So everybody can, have a medical care in United States or Europe, or like this patient without any information from the previous doctor. It's just like, you go to the jungle and you don't know what to do. And since there is a dry tap, so I proceed for a second stage. And then I do an revision second stage. Okay. Can you go further, maybe?
So the question, I think it's interesting. You feel like it's infected, something happened, and then you do again a new ESR and CRP, test, and then the CRP goes a little bit down. Do you guys rely on the CRP to make the diagnosis of infection, or in such case, would you be like, no, it doesn't change anything. I'm still, doing I'm still going to take care of this patient the way I was planning to do it, and it's a chronic infection, and doesn't really matter if the CRP is going down or not.
So maybe two things, I guess, in answer to that, Seb. The first is that CRP is useful to diagnose infection, but it's not great at excluding it. So if it's low, well, that's life. But the second point is, what's the other diagnosis that's going on here? If it isn't an infection, what's made those implants fall out of the bone? Because I'm not sure there is another diagnosis. And in the face of that, whatever the CRP is, you're going to continue with your management plan, I think.
Yeah, makes sense. Makes sense. And the literature is exactly in that direction, especially in case of, low-grade infection. And you can have up to 20% of the case with, ESR and CRP close to normal. So that definitely we should not rely only on ESR and CRP to make the decision, the diagnosis of PGI or not. Excellent. So if we keep going on that, we consider this case, and we rely on the, the international consensus missing criteria. And here we kind of in between, we are score of 3, so it's possibly infected, even if, as you said, for all of us, I think the infection is really the diagnosis number 1. We can see that CRP and ESR are part of the score. Again, there are two, the international consensus meeting, the definition evolved a little bit, but again, it's useful to try to make the decision if you're, in a situation which is not clear enough. Then we have to discuss the management options. We discussed this already with the different previous cases. I think here, Sam, even if the patient is fragile, you would not, you would not defend that option, I'm pretty sure. And then between 1 stage and 2 stage, I mean, let's see if someone would go for something different than 2 stage. Philippe, I'm sure no.
No, you are right.
Dan, I know the answer. Sam, Sam, 2 stage. and yeah, and Nico, you told us already that 2 stage was what you've been for. So again, we can go through the literature, but we said that they're definitely not indicated. And again, 1 stage we mentioned that here a lot of things not in favor of 1 stage, especially because here we don't have the identification of the organism. So 2 stage is definitely where we have to go. Maybe just show the video plays here.
Yeah.
You can see here that the femur was obviously completely loose. And as we mentioned, the joint was dry, but what is dry, you know, it's not clear. Of course, Dan mentioned already in that case to get some fresh frozen biopsy, which is trying to get some more, you know, ideas about the infection. And then you can see that the implants, you know, and again, I would like to thank Nico for sending these intra videos to show that, you know, in that case, removing the implants were not, it's pretty easy.
I have a question, sir, to the panel.
Yeah, Nico, go ahead.
Yeah, if you look at the tibia is still very fixed. My question is, can you lift the tibia like this? Can I have opinion from the panelists? Miles?
Well, Nico, I will admit to leaving the patella in two-stage revisions for sepsis, but I would never leave the tibia in. I would definitely remove that tibia as part of a two-stage.
But some of the British do this, right, Sam? I've seen some literature from England.
Really?
Yeah.
I don't know these people. You have to introduce them to me, Nico. We'll have to talk to them. I can't see any reason why you would leave a tibia in that case. But you know, look, all sorts of things happens in the world. I guess we're here to say what should happen. You should take it all out.
Sebastian, there have been a couple of questions that have come through about what would the panel advise in terms of antibiotics in the setting where you simply don't get an organism. You've taken it out, you've aspirated it, you've sent multiple samples and they're sterile. Which antibiotics would you recommend? And then would that help you direct what antibiotics you put in your cement? Or can we advise about that? Perhaps I could ask that of Dan.
So we routinely will place for our spacers vancomycin and tobramycin in the cement at fairly high doses. And when we don't culture a bug, we obviously get our infectious disease colleagues to weigh in, but typically they'll do something like vancomycin and an aminoglycoside as well as rifampin to treat these.
Okay, so quite a significant morbidity at times with some of those antibiotics, but that's what we have to do. So, Sebastian, back to you.
Yeah, I keep going. You can see the spacer post debridement. So it's an articulated spacer. You can see that Nico managed to take care of the bone loss on the femur and on the tibia to get it, you know, a pretty stable spacer. And then a couple of questions, you know, we mentioned also some of these, you know, the need for antibiotic holiday, the timing for second stage, and maybe also, you know, regarding the, yeah, we mentioned that antibiotic holiday. Let's say about the timing of second stage. Let's say, Dan, when you, for this case, what's going to be the key factors who's going to help you to decide when you would perform the second stage in this case?
So again, typically we do 6 weeks of intravenous antibiotics and then give them an antibiotic holiday for anywhere from 2 to 6 weeks. Follow the laboratory studies. If the CRP and sed rate are normalized, then we'll go back in and do frozen sections at the time before we put in the definitive implants. The challenge is that oftentimes the ESR and the CRP drop but still stay higher than normal, and then it may be worth an aspiration to do that prior to going back in. But again, we make our final decision frequently based on the intra-op frozen sections at the time of the second stage.
Philippe?
In such a situation, I would do at the beginning exactly like Dan, but after 6 weeks, if the ESR and the CRP are not normal, I would consider a second look and remove all the spacer and wait for 1 or 2 weeks before to reimplant a new revision prosthesis. So it happened in only 3 cases where we did this second look and where we removed the spacer, but we didn't reimplant immediately the prosthesis. And so sometimes it gave us, I would say, more visibility and probably better biology constant.
So it's kind of 3-stage revision.
Yes, I know we're discussing mainly the 1 stage today.
No, it's
but it could happen.
okay. So yes, some questions were also about, should we tailor, the cement we put in the spacer to the sensitivity of the infective organism. Maybe I could ask this to Sam, how do you manage the cement you put in your spacer, if you know the organism, of course?
We fortunate enough to have a multidisciplinary team with a microbiologist and an infection specialist, and they'll give me advice on the most appropriate heat stable antibiotic to mix in with the cement. And that's really the key thing. You can put anything in, but of course the exothermic reaction of the cement setting can denature some of the antibiotics we use. So you have to find a heat stable version that will mix in and not adversely affect the structural strength of the cement too much. So we know that anything we add is going to make the cement a little bit weaker, but then there's a sort of risk benefit that you go through, and adding 2, 3, 4 grams of antibiotic to the mixes of cement is not unusual.
Seb, can I break in?
Sure.
So I think the concern for us is that oftentimes these are polymicrobial infections, even though you only get 1 bug. And in the spacer, we tend to use, again, a combination of both vanc and an aminoglycoside.
Yeah, you're exactly right. This lady, she had several operations, and the high infection in this case. So let's move forward. Regarding the timing of the second stage, do you guys do antibiotics holidays? Sam, answered this question already. There's no clear benefit of that. We mentioned this, and then regarding the ESR and the CRP post-op, you can see it remains still pretty high, but it definitely goes, down. And then here you have the information regarding the bugs, and you have 1 bacteria with Staphylococcus hemolyticus. You can see the sensitivity, and also 1 Candida parapsilosis, which is sensitive to fluconazole. And Nico, I will ask you the question about this, because again, you know the case. Is it for you good news, or definitely bad news when you have such answer from your bacteriologist?
Yeah, it's just a good question, Sad. After I got this result, then I have to find first what is Candida parapsilosis. It's very rare. So, and also the Staphylococcus hemolyticus. And so this is, then I look at the literature shows that Staph hemolyticus, it is some sort of multi-drug resistance. It's quite difficult to treat as well, and it's able to form a biofilm. And also we give rifampicin for that. And yeah, that is quite interesting, because I read that Candida parapsilosis is more common in Southeast Asia, while the other one just now, the cloacae, is more in Europe and in United States. So it is very interesting. Yeah. I think most of you never heard about this
No, Candida? No, maybe
Yeah.
mites? No?
No, not in a prosthesis. I've heard of the organism, but I've never seen a Candida infection in a prosthesis.
So in this case, Nico, how long will you wait before second stage?
It's a good question, because if you look at this is a Candida as well, so I'm gonna put a bit longer time, because I'm worried for the Candida. Yep, for the fungal. Yeah, this is what I told you.
Yeah, no, it's very unusual.
Yeah.
It's not more frequent when there is immunodepression.
Sorry?
Yeah, the higher risk for immunodepressed patient. Because this lady, she was young and she had no specific medical history, so that's pretty surprising. Okay, good. I think Miles, that was a tricky case, but I think it's important to see that, you know, we need to stick to the plan, even if some of the information we have can be, you know, sometimes like the CRP and ESR are not exactly in line with what we were expecting. We should still consider, you know, doing the things the right way when we think about infection.
Yeah, can I information?
Yeah, sure.
When I look at the literatures about this this parapleurosis, it is they claim that it's a low grade with pain and swelling, and that is one of the reasons why, you know, if you look at the joints, quite okay, but it's very progressive for the periprosthetic radiolucency. So that's what I read on it.
Yeah, very specific.
Yeah.
So yeah, so the take-home message, you know, is we should do the things right. Radical debridement is critical, and also, you know, that when you have such an infection, you have to be cautious for a second stage reimplantation. Miles, now it's for you for the final case.
Okay, thank you, Sebastian. So this is a patient that I took over the care of, a 78-year-old male, had a primary total knee in 1997, and he was really quite well until 2011, when the knee became, I'm sorry, I'm keeping jumping over here, quite well until 2011, until June when he had a revision for a loose implant, and afterwards he had cellulitis and a painful knee, and he came to see me. I then took over his care. That was his imaging studies, and sorry, that was his leg, and here's his imaging studies. He's having trouble walking. He can't walk unassisted. He's got poor range of motion, and he's got an elevated CRP of somewhere between 45 and 50. There is imaging studies, and I think if there's a lesson here, it's that if you leave an infection for a long time, it does eat away at the bone. That's his plain radiographs. I removed that implant and put in a temporary articulating spacer, as you can see, and then we've got a CT scan. So this is all about bone loss. And the question I have now, and perhaps I'll start with you, Philippe, how would you address this in as a revision situation?
The first things, I would be concerned by the cellulitis, and I would be cautious with that, and I would check if the patient has some anti-inflammatory and things like this, because it's not so frequent to have this kind of cellulitis, and it's very dangerous. This is the first point. And here, when I look at the X-ray, it seems to have a big defect, but this is very small images for me. And he has a big defect on the tibia, huh? That's correct? Or this is
Correct. Yes, he has a big posteromedial tibial defect. You can also see that he has a posterolateral femoral defect. Do you think this is reconstructible?
Yes. I would say yes. You can always shunt this part at one moment. It's I had the feeling that the diaphysis has a very small canal also, and but I think we can feel at one moment and use a bypass of the defect. It's I don't know exactly for the case because there is not so many images, but I remember some case where I place like a kind of nail under the tibia, and I use a keel with a screw.
Thanks, Philippe. Briefly, Sam, do you think this is reconstructible?
Well, I haven't seen probably quite enough images to make a definitive decision on that, but it looks to me as though there's probably enough of a circumference on the tibia and certainly on the femur to reconstruct this, yeah. And then look, you know, I would look to get some sort of fixation probably in the metaphysis with something extending down into the diaphysis as well, and get your 2 zones of fixation there. But I think I'd need to see some more imaging than that, to be fair. I'd want to look through the axial slices very carefully.
Sam, as one of the authors of the original paper on zonal fixation, are we going to get 2 out of 3 zones here at all?
I'd certainly try, Miles. Otherwise, I'd get a hell of a zone 3.
Thank you. Well, look, we're running out of time, so I'll just briefly move forward. This was an example of a case where I think we needed to have a custom-built implant, which is what we did. And that was in 2012. And he was one of these patients with his temporary spacer. He went away on overseas holidays. He cruised around on ships in the Pacific. It took about 18 months before I finally convinced him to have this reconstruction done. And it's still in there and he's still walking.
Yeah. I have a case where I use a little bit less metal, but the same type of long stem with a screw. And after a few years, some bone reappear at this part of the metaphysis. And it was very strange to see that the natural evolution was not so catastrophic.
Okay, I think now I can hand back over to you, Sebastian.
Well, thanks a lot, Miles. I would like to first to thank, you know, our faculties have been fantastic for, you know, answering all our questions. And actually they've been really good, so that was great. And thanks to Dan, Sam, Philip and Nico for being so brave, you know, having no idea of what we're going to ask, and being so accurate and, you know, and relevant with your answers. I would like also to thank Miles. You know, it's been great to co-chair this session and this webinar with you, Miles. A lot of fun, and also we learned a lot. I would like to thank, you know, ISAKOS for the strong support we had to putting this together. That they've been really great for that, and the technical team has been really good. And I would like also to thank all the knee arthroplasty committee members. You know, they have been strong support also for us to putting this together. So knowing that, you know, thank you all. Thank you to all the attendees. They have asked excellent questions. We tried to answer to most of them. We probably had no time to answer to everyone, but we tried to answer most of them. And we're looking forward to seeing you all for the next ISAKOS webinar in the near future. Thank you all. Take care and see you very soon.
Thank you.
Bye-bye.
Thank you very much to the webinar chairs, faculty, and attendees. ISAKOS will host the recorded webinar with the presentations on the ISAKOS Global Link site. We encourage those new to ISAKOS to explore Global Link while it is currently a free educational resource until the end of August. Webinar attendance certificates will be provided to registered attendees via email. Please save the date for the ISAKOS Congress, November 27th through December 1st, 2021 in Cape Town, South Africa. And please don't miss our other upcoming ISAKOS webinars, including one presented by ISAKOS and AppCast on Friday, August 14th, 2020, titled Posterior Shoulder Instability, Diagnosis and Management, and another presented by the ISAKOS Knee, Sports, and Preservation Committee titled Osteotomy Around the Knee, a Powerful Tool for Joint Preservation, which will be Thursday, August 27th, 2020. ISAKOS webinars are supported in part by an educational grant from contributing sponsor Smith & Nephew. Thank you so much, and have a great day.